Seborrheic dermatitis is a chronic inflammatory skin disorder, predominantly affecting areas rich in sebaceous glands, such as the scalp. Its exact cause remains elusive, but factors like Malassezia yeast colonization, immune responses, and environmental influences like stress and climate are thought to play roles. This condition is marked by episodic flares and symptom-free intervals, presenting with erythematous, scaly patches, or greasy yellow crusts, potentially accompanied by discomfort or itching. Epidemiology, more common in males than females, shows a bimodal age distribution, peaking in infants aged 2 weeks to 12 months and during puberty to early adulthood. Etiology, the precise cause is unknown but is associated with the yeast Malassezia. Risk factors include Parkinson's disease, immunodeficiencies like HIV, oily skin, and androgenetic alopecia. Pathophysiology involves the colonization by Malassezia furfur yeast, triggering an inflammatory response in susceptible individuals. Clinical features manifests as erythematous plaques with scaling to greasy yellow crusts in sebum-rich areas, scalp, dandruff, nasolabial folds, eyebrows, periocular regions, and cheeks. Differential diagnoses: atopic dermatitis, which usually presents with dry lesions. Contact dermatitis, characterized by rash distribution, reflecting the pattern of external exposure. Treatment: topical antifungals like ketoconazole are the first-line treatment. Topical corticosteroids may be used for severe acute flares. Special consideration: infantile seborrheic dermatitis, cradle cap, appears shortly after birth, predominantly on the scalp, showing erythematous scaling plaques that evolve into greasy, yellow scales. Differential diagnoses include atopic dermatitis, which typically emerges later, and diaper dermatitis, which spares skin folds. Despite treatment, seborrheic dermatitis is recurrent, with patients experiencing flares throughout their lives. Early management of acute episodes and maintaining skin health can help control symptoms and improve quality of life. Clinical case: infantile seborrheic dermatitis, cradle cap. Patient information: age 6-week-old male, medical history, first child, uncomplicated full-term pregnancy and delivery, no significant family history of skin disorders. Presenting complaint: the mother brings her infant to the pediatric clinic, concerned about a scaly, greasy rash on the baby's scalp and some areas on the face. History of present illness: the mother first noticed the rash about 2 weeks ago. It began on the scalp and then appeared on the eyebrows and behind the ears. The baby appears otherwise healthy, with normal feeding and sleeping patterns. The mother denies any recent illnesses, fever, or changes in baby products. Physical examination: general. The baby is alert, active, and appears well-nourished. Skin: erythematous patches with thick, yellow, greasy scales on the scalp, most prominent over the vertex. Similar, albeit less extensive, lesions are noted on the eyebrows and post-auricular regions. No signs of irritation or discomfort are observed. Diagnostic workup: clinical diagnosis. Based on the characteristic appearance and distribution of the rash, a clinical diagnosis of infantile seborrheic dermatitis is made. Further testing: generally not required unless lesions are atypical or not responding to standard treatments, in which case a skin swab or biopsy might be considered. Management plan: 1. Reassurance. Educate the mother that this is a common and benign condition in infants, usually resolving spontaneously within a few months. 2. Skin care. Recommend gentle washing of the affected areas with baby shampoo and soft brushing to remove scales. Advise against aggressive scrubbing. 3. Emollients. Suggest the use of emollient creams to hydrate the skin if dryness is present. 4. Topical antifungals. Consider prescribing a mild topical antifungal like ketoconazole if lesions are extensive or significantly inflamed, with careful application as per pediatric guidelines. 5. Follow-up. Schedule a follow-up appointment in 4 to 6 weeks to assess response to treatment and adjust the management plan as necessary. Her outcome. At the follow-up visit, the mother reports significant improvement with daily gentle shampooing and emollient application. Most of the scalp lesions have cleared with only minimal scaling remaining on the eyebrows. The treatment plan is continued, with further follow-up as needed based on symptom persistence or recurrence. Discussion points. The importance of differentiating infantile seborrheic dermatitis from other neonatal skin conditions like atopic dermatitis, which may require a different management approach. The role of conservative management in treating infantile seborrheic dermatitis, emphasizing the condition's self-limiting nature. Strategies for educating parents on appropriate skin care for infants, helping to alleviate concerns and prevent unnecessary treatments. Atopic dermatitis, AD, is a chronic inflammatory skin condition, often manifesting in early childhood, with a tendency to improve or become a lifelong issue. It's frequently associated with other atopic disorders like asthma and allergic rhinitis. The exact cause is multifactorial, involving genetic predispositions, such as a family history of atopy and mutations in the FLG gene affecting skin barrier function, as well as various environmental and internal triggers. Key features: pruritus and dry skin, the hallmark symptoms of AD, leading to discomfort and impacting quality of life. Age-related distribution: infants, eczema predominantly on the face, head, and extensor surfaces, sparing the diaper area. Children, involves flexural areas like the antecubital and popliteal fossae with skin thickening. Adults, features lichenified lesions on flexor surfaces and may include nummular eczema. Associated features: Denny-Morgan folds under the eyes, and the atopic triad of asthma, allergic rhinitis, and AD. Diagnosis: based on clinical criteria, including the presence of pruritus and eczema, with additional findings supporting the diagnosis, such as elevated serum IgE levels, personal or family history of atopy, and other atopic diseases. Management: skin care, regular moisturizing to manage dry skin and pruritus. Avoidance of triggers, such as allergens, irritants, and extreme temperatures. Topical therapies: steroids and calcineurin inhibitors for flare management. Systemic treatments: for severe cases, options include phototherapy or immunomodulating agents. Complications: secondary infections, particularly with Staphylococcus aureus, which can exacerbate the condition. Eczema herpeticum, a serious complication from herpes simplex virus infection on eczematous skin. Clinical case scenario: imagine a 4-year-old child brought to a dermatology clinic by concerned parents due to persistent itching, dry skin, and eczema localized to the flexural areas of the limbs. The family history reveals both parents have allergic rhinitis, and the child has intermittent asthma. The eczema is lichenified, indicating chronicity. Initial management includes education on trigger avoidance, proper skin care with emollients, and the judicious use of topical steroids during flare-ups. Given the family history and the child's asthma, there's a strong consideration of atopic dermatitis, with plans for close monitoring and adjustments in treatment based on the disease course and response to therapy. Psoriasis is a chronic inflammatory skin disorder marked by a predisposed genetic background and influenced by various environmental triggers. This condition is characterized by the development of well-demarcated erythematous and scaly plaques, often accompanied by pruritus. These lesions predominantly appear on the scalp, presacral region, and extensor surfaces, such as knees and elbows, though they can affect any skin area. Psoriatic arthritis, a related inflammatory arthritis, affects up to 30% of psoriasis patients, involving joints and potentially leading to severe joint damage. Epidemiology: psoriasis commonly presents with a bimodal age distribution, initially appearing in early adulthood. Etiology: triggers include infections, notably B. hemolytic streptococci, mechanical irritation, and certain medications like beta blockers. Pathophysiology involves rapid keratinocyte proliferation and inflammation mediated by T-cell cytokines, resulting in characteristic skin changes and potential joint involvement. Clinical features: cutaneous, sharp-bordered, red plaques with silver-white scaling, commonly on the scalp, trunk, and extensor surfaces. The Auspitz sign, pinpoint bleeding when scales are removed, and the Koebner phenomenon, lesions forming at sites of skin trauma, are characteristic. Nail involvement, pitting, brittleness, and onycholysis. Psoriatic arthritis can manifest as asymmetric oligoarthritis, particularly affecting distal and proximal interphalangeal joints, and may lead to severe forms like arthritis mutilans. Diagnostics: primarily clinical, supported by typical findings on skin biopsy such as acanthosis, parakeratosis, and Monroe microabscesses. Differential diagnoses: atopic dermatitis, seborrheic dermatitis, and other scaling disorders can mimic psoriasis, but differ in lesion characteristics, distribution, and associated features. Management: mild cases are treated with topical agents like corticosteroids. Moderate to severe psoriasis may require systemic treatments, including biologic agents targeting specific immune pathways involved in psoriasis pathogenesis. Clinical case scenario: consider a 35-year-old individual with a history of occasional dry, itchy patches on the elbows that have recently become more prominent and widespread, including the scalp and knees. The patient reports significant itching and cosmetic concern. Physical examination reveals erythematous plaques with silvery scaling, particularly pronounced on the extensor surfaces and scalp. Given the clinical presentation, a diagnosis of plaque psoriasis is made. Initial management includes topical corticosteroids and moisturizers, with a discussion on potential triggers and lifestyle modifications. A follow-up is scheduled to assess response and consider additional therapies if necessary. Impetigo is a common pediatric skin infection, primarily caused by Staphylococcus aureus and sometimes Streptococcus pyogenes. It presents in two main forms, non-bullous and bullous impetigo, with non-bullous being more prevalent. The condition is characterized by honey-colored crusted lesions that are often surrounded by erythema, commonly appearing on the face and extremities. Epidemiology: predominantly affects children aged 2 to 6 years. Highly contagious, making it a frequent bacterial skin infection among children. Etiology: Staphylococcus aureus, responsible for both bullous and non-bullous forms, accounting for approximately 80% of cases. Streptococcus pyogenes, typically associated with the non-bullous form. Clinical features: non-bullous impetigo, begins as papules that progress to vesicles pustules, with surrounding erythema, eventually rupturing and forming the characteristic honey-colored crusts. Lesions heal without scarring and may be itchy, but rarely painful. Bullous impetigo, characterized by the formation of large, flaccid bullae that rupture and leave behind thin brown crusts, mainly affecting the trunk and extremities. Diagnosis: primarily clinical, based on the appearance of lesions. Bacterial culture can confirm the diagnosis and identify the causative organism. Treatment: mild cases. Topical antibiotics like mupirocin are the first-line treatment. Severe cases. Systemic antibiotics may be required. Complications: while generally uncomplicated, gas-caused impetigo can lead to acute post-streptococcal glomerulonephritis, PSGN. Clinical case scenario: imagine a 4-year-old boy brought to a clinic by his parents, concerned about rapidly spreading sores around his mouth and on his hands. The lesions started as small red bumps before rupturing and forming a yellowish crust. The child has been scratching the itchy lesions, potentially spreading the infection. Physical examination reveals classic signs of non-bullous impetigo with no systemic symptoms. Given the clinical presentation, impetigo is diagnosed and treatment with topical mupirocin is initiated with advice on hygiene practices to prevent spread. A follow-up is scheduled to ensure resolution and assess for any signs of complications. Erythema toxicum neonatorum, ETN, is a common and benign skin condition that typically affects newborns within the first few days or weeks of life. Despite its somewhat alarming appearance, ETN is harmless and resolves on its own without any treatment. Clinical features. Appearance. The rash begins as small red macules, flat spots, and papules, small bumps, which can develop into pustules, small blisters containing pus. Each lesion is often surrounded by a patch of redness, erythema. Distribution. The rash predominantly appears on the trunk and proximal extremities of the newborn. It characteristically spares the palms of the hands and soles of the feet, which helps differentiate ETN from other neonatal skin conditions. Symptoms. ETN is not associated with any systemic symptoms and does not seem to cause discomfort or itching for the infant. Diagnosis. The diagnosis of ETN is usually made based on the characteristic clinical appearance of the rash. No specific diagnostic tests are required. Management. Reassurance. Parents should be reassured about the benign nature of ETN and informed that it will resolve spontaneously. Observation. No treatment is needed for ETN. The rash typically resolves on its own within a week or two, though it can occasionally last up to a month. Clinical case scenario. A 5-day-old infant is brought to the pediatric clinic by concerned parents due to the sudden appearance of a rash. The parents report that the baby is otherwise feeding well, has normal diapers, and does not seem to be bothered by the rash. On examination, you observe scattered small red macules, papules, and a few pustules with a halo of erythema, predominantly on the baby's chest and thighs, but not on the palms or soles. Given the clinical presentation and the baby's age, you diagnose the infant with Erythema toxicum neonatorum and reassure the parents about its benign nature, advising them that no treatment is necessary and the rash will resolve spontaneously.